Greetings from Miami. I'm a fellow neuroendocrine tumor enthusiast. Thank you for joining us a wonderful afternoon today. My name is Aman Chauhan. I'm a medical oncologist, and my area of clinical expertise as well as research interest is neuroendocrine oncology. Lead our neuroendocrine cancer program at University of Miami Sylvester Comprehensive Cancer Center. Before we go forward, just a couple of words here. This is a CME accredited activity, and we are also grateful to the sponsors. This is activity sponsored by Exelixis. As far as my disclosure is concerned, I serve on advisory panel for these entities, and i3 Health has mitigated all relevant financial relationships. All right, so what are we going to talk about today? Well, we are going to discuss neuroendocrine oncology and the latest advances we've made both in diagnostics, management, and treatment. If I have to consolidate, we would like to the audience after this talk be able to recognize the varied presentations of neuroendocrine tumors, because that is a key component of diagnosis and is also a key challenge in neuroendocrine oncology. Identify patients who are at risk for recurrence based on some of the well-studied risk factors, and develop guideline concordant personalized treatment plans for neuroendocrine cancer patients. And we'll discuss some of the recent clinical trial findings and latest developments in this regards. So what is a neuroendocrine tumor? Well, these are tumors or growth in specialized cells called neuroendocrine cells. These cells are found in many places in the body, primarily in the lung and GI tract, but it's not uncommon to see in very obscure places, ovaries, breast. I had a couple of cases of middle ear neuroendocrine tumor, head and neck. So these are cells that are present in all of us and have some physiological functions. But when something goes wrong inside of these cells that makes them grow uncontrollably, it becomes a tumorous growth, and they lead to developing these neuroendocrine tumors. Many of these tumors may not become metastatic, but some of them certainly have the potential to become a true cancer where it grows and spreads and metastasizes to other organs. It's very important to know about these cancers. As I mentioned earlier, these tumors can stem out from these specialized neuroendocrine cells from anywhere in the body, but by far the commonest metastatic neuroendocrine tumors are often seen from midgut primary or small intestinal primary, followed by thoracic, so lung NETs, and pancreatic neuroendocrine tumors. We also oftentimes see rectal neuroendocrine tumor, gastric neuroendocrine tumors, and these are oftentimes caught very early in the polypoidal stage when patients undergo EGD or colonoscopies for respective issues. So why do we need to know about these relatively rare neoplastic condition? Well, in front of you, this is the recent SEER database. This was just published by Dr. Dasari last month. And as you can see here in front of you, while the incidence of all major malignancies, as depicted by the line in the blue on top, has remained stable for past 50 years. In fact, maybe slight decline because perhaps better behavior patterns like smoking cessation. If you look at the neuroendocrine tumor incidence, in contrast, it has spiked 7 or 8 folds. In 1970s, when we used to diagnose 1 case per 100,000, fast forward to now, 2021, 22, the recent data we have, it's almost 7 or 8 per 100,000. Significant spike in the incidence of neuroendocrine tumors. Moreover, many of our neuroendocrine tumor patients, because they are low grade, they're slow growing, the prevalence of disease far outweighs the incidence, because every single year, hundreds and thousands of cases, they accumulate. So the overall burden of neuroendocrine cancer globally, and certainly in the US, is vastly disproportionate to its incidence. And as of today, it is expected that there are well over 200,000 patients with the diagnosis of neuroendocrine cancer of some form exists in the US, and putting the prevalence of neuroendocrine tumors among the top 5 GI cancers in the US. Well, we'll kind of now take a deep dive into various forms of neuroendocrine cancers and presentations. Well, the one way to define neuroendocrine tumors is how it presents. So there are some neuroendocrine tumors we call functional neuroendocrine tumors, while majority are non-functional. What does that mean? Some neuroendocrine tumor, they secrete a hormone or a vasoactive chemical or peptide that gives certain specific symptoms. You've heard of carcinoid syndrome. Carcinoid syndrome is a neuroendocrine tumor, oftentimes starting from small bowel with liver mets. And these tumors in the liver, they secrete excessive serotonin. And this excessive serotonin can give patients symptoms like wheezing, flushing, turning red on the face, diarrhea, and then several other less commoner symptoms of carcinoid syndrome like muscle aches, fatigue, mood disturbances, etc. That clinical triad of flushing, wheezing, diarrhea is often called carcinoid syndrome, but there are a whole list of other less common symptoms that can be associated with elevated serotonin. Similarly, pancreatic neuroendocrine tumor, if it secretes VIP, vasoactive intestinal peptide, it can give patients really bad diarrhea. Gastrin is another hormone that some of these NET patients can secrete. So excessive gastrin secretion can lead to peptic ulcer disease, a lot of gastritis, and patient are known to have Zollinger-Ellison syndrome. That's a manifestation of elevated gastrin neuroendocrine tumor patients. Another such hormone is glucagon, that causes your sugars to go up. Insulin, that causes sugars to go down. So it depends on what hormone with the neuroendocrine tumor secreting, they can have appropriate clinical symptomatology. But as I mentioned before, majority of neuroendocrine tumors are non-functional, so about 70%. And these patients are often asymptomatic. They are either diagnosed incidentally, somebody got a scope or a scan for some other reason and we found tumor, or sometimes these patients can present with mass effect. That means the tumor is pressing on certain organ nearby, causing the patient to have pain, causing the patient to have some breathing difficulties or obstruction because it was wrapped around near the bowels. So it could be a mass effect related symptoms. All right. Now let's describe the terminology of neuroendocrine tumors. Well, neuroendocrine neoplasms, or the growth of neuroendocrine cells, it's truly a spectrum of disease rather than one disease. On the benigner end of the spectrum, we have low-grade, well-differentiated neuroendocrine tumor. On the more aggressive end of the spectrum, we have high-grade, poorly differentiated neuroendocrine carcinomas. And just like GI tract neuroendocrine cancers, lung has its own terminology, but they are speaking the same, they mean the same thing. So on the benigner end or less aggressive end of spectrum lies the well-differentiated neuroendocrine tumor, often called typical carcinoid. On the more aggressive end of the spectrum lies the poorly differentiated neuroendocrine carcinomas like small cell lung cancer and large cell neuroendocrine cancer of lung. So this is how we classify neuroendocrine cancers, and based on their morphology, pathology, they are subdivided into different types. For today's talk, we will be focusing on NET, well-differentiated neuroendocrine tumor, and not talk about poorly differentiated neuroendocrine carcinoma. So for clarity, I have synthesized this spectrum into these easy to recognize labels. So if I have a new patient that I see, the first thing I look into the pathology report and ask myself, am I dealing with a neuroendocrine tumor patient or a neuroendocrine carcinoma? Because the thought process about the management and the treatment will be very, very divergent. If it is a neuroendocrine tumor patient, or otherwise also called well-differentiated neuroendocrine tumor, then I need to also figure out, is it a grade 1, grade 2, and grade 3 tumor? And our pathology colleagues, they help us figure this out. They either grade these tumor based on mitotic index or Ki-67 percentage. For lung neuroendocrine cancers, however, it is encouraged to also study Ki-67 index. However, mitotic index is the acceptable way to grade lung neuroendocrine tumors. For all other, Ki-67 is commonly used in addition to mitotic index. So a couple of words about the unsung heroes, our pathology colleagues. I think they provide us the most vital and crucial piece of information that enables us to come up with a good, sound management plan. So what you see in front of you is a biopsy sample, a histopathology slide from a neuroendocrine tumor patient. So I would like for audience to focus on right side of the screen here during my cursor. These are neuroendocrine tumor cells that are being stained for Ki-67, which is sort of a brownish colored dye. And if you see here, these are the cells that are stained. So if you see in the totality, very few, probably less than 3% cells are stained. So this puts this tumor at grade 1. So the definitions are less than Ki-67, less than 3% grade 1, between 3 and 20 is grade 2, more than 20% is grade 3. On the contrary, if you are managing a NEC patient or poorly differentiated neuroendocrine carcinoma patient, that we will not be discussing today in our talk, but just for the context, it's a very different disease. And look at the Ki-67 here, it's probably well over 90%. So it's a very aggressive disease, very fast-growing disease. So if we have a patient with small cell carcinoma of pancreas or rectum or lung, we oftentimes see them very fast, sometimes get them admitted and start chemotherapy right away. So it's a very, very different disease. So it's really important to get that understanding. Are we dealing with the NET or NEC? And if it is an NET, what is the grade of NET? All right. In past, I would say 2010, 2015, we had basically NET or NEC, and anything grade 3 is always automatically NEC. And I'll show you the difference between the outcomes of NET and NEC. The top line is a Kaplan-Meier curve of survival, disease-specific survival in low-grade NET. And the survival, the median survival is in months and years as compared to NEC, the one in red. These are your small cell carcinoma or poorly differentiated neuroendocrine carcinoma. So the distinction was quite stark. Either patient has a grade 1, grade 2 NET, or they have a grade 3 NEC. There was no such entity called grade 3 NET. But over the years, we recognized that there are some patients who are not as aggressive as NEC, but they're also not as indolent as grade 1, grade 2 NET. So that led to characterization and recognition of this distinct entity, the grade 3 well-differentiated neuroendocrine tumor. So now we have 3 grades of NETs, grade 1, 2, and 3. And then there is NEC, which is by definition always grade 3. So that was an important recognition in 2017 WHO classification. Now, the key determination between NET, NEC, and between the 3 grades of NET, 1, 2, and 3, this is all done by our pathology colleagues through immunohistochemistry stains, through their morphology, the looks of the cancer, etc. But we also now know, with the help of molecular testing, that these are distinct. These subgroups are not just different on the surface of the looks, but their molecular fingerprinting, their underpinning, genetic underpinning is also very distinct. Look at the NEC, for example. NEC cases often exhibit mutation in TP53 and retinoblastoma, one loss of RB1, etc. As compared to when we are dealing with another high-grade tumor, but not NEC, but NET, grade 3 NET, or well-differentiated NET, the mutational pattern is different, and you'll oftentimes see mutation in MEN or DAX, just like other grade 2 and grade 1 NETs. So well-differentiated, poorly differentiated are different diseases altogether. So I would wrap up this section by a couple of clinical pearls. Very important to understand difference between NET and NEC. These are not interchangeable. Grade and what is Ki-67 or mitotic index is a key question that I encourage my patients to ask whenever they are seeing the provider, so that we understand, are we dealing with a slow-growing disease, a better biology, or are we dealing with a more aggressive disease that we need to monitor closely and keep treatment ready in case the original treatment doesn't work. It is also encouraged that pathology should be reviewed at high volume centers, because it's not uncommon for us to see a lot of discrepancy between two pathology reads, not because it is, the pathology quality is bad at a lower volume center. These are just very difficult diseases to diagnose. And there could be difficulty in, for example, figuring out atypical carcinoid versus large cell neuroendocrine carcinoma. So having path reviewed by somebody who sees it more commonly, it's not a bad idea. All right. As I mentioned before, these neuroendocrine tumors can stem out from various different organ systems. While for today's talk, we will be focused on well-differentiated neuroendocrine tumor of pancreas, of lung, or of small intestines, which by far covers majority of neuroendocrine cancers. There are certain rarer subgroups of neuroendocrine cancers, like you've probably heard of paragangliomas and pheochromocytomas. Those are seen in adrenal gland, and thyroid, medullary thyroid tumor cancer, which is a type of neuroendocrine tumor. Merkel cell carcinoma is a type of high-grade neuroendocrine cancer of skin. So there are different types of neuroendocrine cancers as well, but the one that we are focused on today, the neuroendocrine tumor well differentiates, are the bronchial NETs, the pancreatic NETs, the midgut NETs. All right. One specific nuance about functional neuroendocrine tumor. If you remember, I defined that there are about 20-30% of cases which present with functional syndrome because the tumors are secreting certain hormones. And one of the commonest functional syndrome is carcinoid syndrome, where the neuroendocrine tumors, they secrete serotonin, excessive serotonin. So what's the big deal with these excessive serotonin? Not only it gives patient quality of life, limiting diarrhea, flushing, fatigue, wheezing, but it's also pretty detrimental for patient's heart. It's well studied, the effect of elevated serotonin in uncontrolled carcinoid syndrome patient. And they develop something called the carcinoid heart disease, where the serotonin literally eats up, damages the valves of the heart. And since most of this is happening on the right side, because these are the tumors from small intestinal net lodged in the liver, secreting the serotonin, and the venous return on the right side of heart that first exposes the tricuspid valve. So tricuspid valves are oftentimes the first one to go. And it leads to a classic right-sided heart failure. So the key here is to recognize this sooner and prevent this from happening. Because once a carcinoid heart disease develops, it's a very bad disease and difficult to treat. And as you can see, the survival between patients who have carcinoid heart disease versus not, it's almost, the mortality is 100% higher. So you significantly increase the mortality risk once the carcinoid heart disease sets in. So it's very important to screen for this, get a baseline echo in patients with elevated serotonin or carcinoid syndrome patient, and monitor it with yearly echoes. So this is the second segment of the talk, and I'd like to wrap up by this slide, neuroendocrine cancers is truly a nuanced disease because it comes in different flavors based on the amount of disease at presentation, low volume versus high bulk disease, widely metastatic versus just in the liver. So there are a lot of patients who present with liver dominant disease, and treatment might differ a little bit because for a liver dominant disease, we may just stick with embolization or liver directed therapies. Low Ki-67 index or low mitotic index versus high, more aggressive disease, where we may oftentimes use chemotherapy. Based on the site of the disease, the nature of neuroendocrine tumor might subtly differ. For example, pancreatic NETs oftentimes can present with functional syndrome like insulinoma, glucoconoma. Midgut or small intestinal might present with carcinoid syndrome, etc. Clearly, grade is very important, and grade certainly prognosticates the disease. So higher the grade, more aggressive the disease, worse the survival. Morphology is also very important between the NET and NEC. Clearly, NEC morphology is extremely poor prognosis with median survival a year and a half as compared to well-defined NET, where the median survival goes on to years. There are patients of mine and others who live with this disease sometimes for decades. It's a very different disease. We also learned about functional and non-functional nature of the disease based on the ability of these tumors to secrete certain hormones. Last but not the least, some of these, actually majority of the GI origin neuroendocrine tumor express somatostatin receptor, and vast majority of lung neuroendocrine tumor also express somatostatin receptor. And we'll talk a little bit about it later because we have leveraged this property of somatostatin receptor expression for both diagnosis as well as therapies in neuroendocrine tumor patients. All right. All this understanding of different nuances of what type, grade, etc. we are dealing with certainly has an impact on what type of management. As you see here, well-differentiated neuroendocrine tumor for diagnosis, we oftentimes rely on a somatostatin receptor scan as compared to poorly differentiated small cell carcinomas where we do FDG PET, which is a different disease. So it's very important. This is just one example. The treatments moving forward are also very different based on what disease we're dealing with. So it's very important to suspect, have a good, thorough physical exam and history, because unless you suspect it, you won't detect it. And zebra is our mascot for neuroendocrine tumors for two reasons. One, in medical school, they teach us when you hear hoofbeats, think horses, not zebras, meaning if somebody's coughing, think about common things, right? Allergies or pneumonia or things like that. You're not going to think a neuroendocrine tumor of lung. But in my world, in rare disease, if you don't think of rare issues, you're going to miss the diagnosis. And it's a well-known phenomena that many neuroendocrine cancer patients are often delayed or in their diagnosis or misdiagnosed early on. And this goes on for years. So it's very important to suspect it so that you can lead to correct diagnosis. The other reason why zebra is our mascot is because no two zebras have identical zebra stripes. It's like fingerprints. So no two NET patients are identical. You can have a grade 1 pancreatic NET and compared to another grade 1 pancreatic NET. One is insulinoma and this is VIPoma. And they may all behave very differently. The growth patterns may be very different. The somatostatin receptor status might be very different. So we have to, unfortunately and fortunately, make an individualized treatment plan. Unlike several other cancers, you can't really follow a cookbook recipe. You really have to understand and individualize each patient treatment. Okay, right. How do we diagnose this? If we have a clinical suspicion, we've done the biopsy, are there any blood tests that can be done? Well, yes and no. We do have a lot of tests that are available to us, and that can be certainly helpful in certain situations. For example, if we are dealing with a carcinoid syndrome patient, we can now detect serotonin level or 24 urine 5-HIAA to look for serotonin levels and breakdown products of serotonin. Somebody is insulinoma, we check insulin level. Somebody has gastrinoma, we can check for gastrin level, and so on and so forth. But majority of neuroendocrine tumor patients, as I mentioned, are non-functional. They are not secreting any hormone. So in those situations, we don't really have a good, reliable way to track the disease based on the blood markers. There is an old blood test called chromogranin A, which has its utility in select cases only. So for every patient, I don't routinely recommend that everybody needs to do it. In fact, recently AJCC consensus guideline just came out, and that advised against routine use of chromogranin. Having said that, there are some patients where chromogranin certainly reflects the disease burden accurately and can be an adjunct to, in addition to the scans. So you need to individualize that. There has been some strides in molecular testing when it comes to neuroendocrine tumor, and there is a relatively new test called NETest. It's now available through CLIA certified labs, and has been shown to be very, very sensitive and specific for detecting NETs and kind of also following neuroendocrine tumor patients. So that's something there. This is one of the studies testing NETest efficacy in terms of as a diagnostic biomarker, been found to be very concordant with the scans. So this is something out there, and there are some more blood-based biomarkers that are still under investigation. This is one of such biomarker that we are investigating, and we found earlier in our pilot study that's significantly elevated in NETs, all type of neuroendocrine cancer patients, and is currently under being validated in multi-center studies. But where we have made significant strides in improving our diagnostic capability is the molecular imaging. We now have access to some very sensitive and specific scans. These are called Dotatate PET scans. One of the first one in the US market was gallium-68 Dotatate, reported to be 90+% sensitive and specific. Look at this patient, same patient who had a older Octrio scan called 111 indium pentatide versus the latest gallium dotatate. Look at the resolution. You can barely see small lesions of liver here, but here you can easily define all the small and the big lesions. In fact, some studies suggest that dotatate PET can pick up disease as small as 3 to 4 millimeters. So it's pretty good. Now we have, I think, 3 FDA-approved products, at least in the US. Copper-64 dotatate PET is also very, very good. Some studies go on and say it's 95, 97% sensitivity and specificity. So let's take a second here and give you guys a mental break, or maybe not, maybe some homework. So which of the following is mandatory for grading lung neuroendocrine tumors? Mitotic index, Ki-67, both, or neither? I'll just give you a minute to think. And so it's a little bit of a tricky question. As I mentioned before, we use mitotic index Ki-67 for GI NETs. But when it comes to lung, officially mitotic index is still the official designated way to grade. However, the recent WHO classification did encourage people to use Ki-67. So the answer would be mitotic index for lung NETs. If it was extrathoracic, the answer would be both. All right, moving forward. Somatostatin receptor imaging is useful in diagnosis of which of the following? NET, or well-differentiated neuroendocrine tumor, NEC, or poorly differentiated neuroendocrine carcinoma, both, or neither? Give you a second to think about that. All right, I think most of you would have got it right, and it's NET. So neuroendocrine tumor, vast majority of GI origin neuroendocrine tumors and substantial lung NET patients will have somatostatin receptors. So it is the test for NETs. When it comes to NEC, very few NEC patients have very high SSTR uptake. So this is not the preferred PET scan for NEC. For NEC, you will do FDG PET. That is the standard PET that we use in other solid tumors. And since NEC is very aggressive cancer, very hypermetabolic lesions, you want to give that FDG dye to them. All right, moving forward, which of the following blood-based biomarkers is highly sensitive and specific for diagnosing neuroendocrine tumors? Chromogranin A, NSE or neuron-specific enolase, both or neither? I think you got it, right? We discussed, although we have a lot of blood tests, unfortunately, the blood tests are not very accurate, at least not the chromogranin and NSE. So the answer would be neither. There would be role for select patient, but as a general rule for majority patient, so it's not very accurate in informing us about the disease status. Chromogranin A can be affected by antacids like proton pump inhibitors and several other drugs. All right, now we move on to the last segment of the talk where we discuss the current treatments, specifically management and systemic therapies. Just a couple of sentences about locoregional disease. So I've tried to consolidate how we manage neuroendocrine cancers, although of course it cannot incorporate everything. But by and large, when we have a neuroendocrine tumor patient, we can divide them into two major categories. It's a local disease or locoregional, so it's still confined to the primary site. For example, if it's appendix, it's just in and around appendix. It's a pancreatic net, it's just in around pancreas, it hasn't spread to liver or bones. Or alternatively, the patient had advanced disease and it's already spread to other organ. The common organs where it often likes to go to is liver, bones, lymph nodes, etc. So if it's a local or locoregional disease, it's essentially a surgical disease. So many patients, vast majority of patients, when they're caught early, you want to resect them because it has been shown in many studies that patient has a long duration of disease-free survival after resection for the local disease. There is still some role for surgery even in metastatic disease. In fact, there are a lot of single institutional retrospective database studies that suggest if we can resect 70 to 90% of the tumor, those patients tend to do better. But unfortunately, these studies are non-randomized and can have observer's bias, can have selection bias. For example, critics may say the patients who are getting surgeries are fitter, healthier patients, and they probably have better outcome. So there is a debate regarding the role of metastatic, so debulking surgery in metastatic disease. But I do think there are certain patients who certainly benefit. These are functional NET patients where debulking them alleviates some of the functional NET syndrome. But there might be some non-functional patients who may also benefit from metastatectomies in NET patients. This is one such example. I'm a medical oncologist, but my earlier work during residency, because I was working with some very good surgeons. In fact, one of my first NETs presentation was at a surgical meeting describing their data and analysis. So this is a NET patient who's undergoing debulking surgery from midgut NET, and see how surgeon was able to resect the disease and suture back. And they call it resetting the clock. We kind of get rid of as much disease as possible and kind of taking their scans to as if they were diagnosed several years back. In our study, we found that patients who had successful debulking surgeries tend to live longer, but clearly these are retrospective data, is non-randomized, and also difficult to get statistical significance in this because patients have to be followed for a long period of time. What about role of adjuvant therapy? The patients who do undergo surgery, there's currently no role for adjuvant therapy. So we only treat patients in NETs if we can see them. So if patient has been resected, there is currently no role for additional chemotherapies. You just then observe them with scans. In fact, one clinical trial is investigating the role of chemotherapy in pancreatic NET as adjuvant therapy, and that is, I think, one of its kind adjuvant trial that we'll look into observation versus adjuvant chemo and will inform us if there's any role for adjuvant chemo in reducing the relapse rate in pancreatic NETs. But the current standard of care is observation. All right. What about radiation? Well, there's no major role for radiation when it comes to well-differentiated neuroendocrine tumors, traditionally thought to be not very radiosensitive, not like small cell lung cancer, which is highly radiosensitive. So there is no major role. If it's an early stage disease, you really want them to get resected. And if it's an advanced disease, then again, systemic therapies are way to go. However, I find that there's a great opportunity to investigate anti-tumor effectiveness of these radiation techniques, especially SPRT, because sometimes we have patients who cannot get surgeries because of medical comorbidities and may really benefit from SPRT or focal radiation. But this is an understudied area, and I think there's some role for additional studies here. The mainstay of treatment for metastatic disease is systemic therapies or medicines. And the next few slides, we will go over some of the advances there. In this slide, we've kind of showcased the advancements we have seen in neuroendocrine oncology. And when I was a resident, we had very few treatments. In fact, we didn't even have PRRT, and we had to send patients outside US to get it. Fast forward to 2025, we have so many drugs. We have problem of plenty now to how to figure out how to sequence these drugs, and a lot of very effective drugs, with cabozantinib being the latest entrant, and and how we manage neuroendocrine tumor patients. All right, so how do we sequence systemic therapies? Well, it's not very clear. We again have to individualize treatment for each patient, but I'll kind of take some liberty and do some generalizations. Okay, for majority of well-differentiated NET patients who have advanced disease, somatostatin analogs are our go-to frontline treatment. They are very effective. They are relatively very safe as compared to radiation, chemo, targeted therapies. And there are patients who stay on SSA for years, and I even know patients who've been on it for 18 years. So again, these drugs are relatively safe and are very effective. After SSAs, it gets a little bit murky. There are a lot of patients who will benefit from Lutathera, lutetium-177, Dotatate, based on NETTER-1 study. But there might be patients who are not SSTR positive, then would not benefit from lutetium-177. In fact, those patients would not even get SSAs. And that's where I said earlier that there has to be a nuance. So if it is SSTR negative patient, like LungNet, then you'll have to try a non-SSTR based therapies like mTOR inhibitor or cabozantinib. If it's a higher grade tumor, very aggressive disease, very fast growing disease, you might want to try some chemo, because these PRRT and other treatments can take time to set up. So you might start off with CAPE-10 and others. So again, there are some nuance to it, but we will go over some of the evidence that may help you treat at least majority of the patients. All right, so as we discussed, somatostatin analogs are one of the mainstay of the treatments, oftentimes used as a frontline treatment for metastatic disease. We have two products, Octreotide and Lanreotide. Lanreotide was FDA approved for tumor control based on this large randomized controlled study called CLARINET. As you can see here, patients who were on Lanreotide is depicted by red line on the Kaplan-Meier curve, has significantly better median PFS as compared to control arm, which was just 18 months. And I think the study arm was over 30 months. So based on this, FDA granted approval for use of Lanreotide for tumor control in well-differentiated NET patients. Although benign, relatively benign as compared to chemo and radiation, no drug is without side effects. So things to watch out for if your patient is on somatostatin analog is hyperglycemia, hyperlipidemia. It can give you gallstones. Some patients can have muscular pain, and injection site granuloma is very common for patients to develop these nodules in the injection site. Some patients can also have steatorrhea, which is a fatty diarrhea. So I oftentimes tell patients not to take too much of greasy food, especially after getting the injection for a day or two. And some patients really can also have pancreatic insufficiency because it's an inhibitory hormone. So it can make it difficult for pancreas to secrete pancreatic juices. So some people can have those digestion issues. All right. While we are on the topic of somatostatin analog, there's another drug I would like to discuss briefly. So this is a diagram of the neuroendocrine tumor cells, and you can see tryptophan, one of the essential amino acids that we get from the diet, gets converted into 5-hydroxytryptamine in various steps. And 5-hydroxytryptamine is basically serotonin, which is stored in the neuroendocrine tumor cell. And any trigger like anxiety or stress or red wine, aged cheeses, a different type of dietary triggers as well that causes these tumor to release the serotonin, and then patient would have flushing and diarrhea and all these carcinoid syndrome things. So one way to tackle it is somatostatin analog that tag on to the somatostatin receptor that is present on the tumor and inhibits its secretion. Okay, this is what we studied. Lanreotide does it, sandostatin does it, and helps with the carcinoid syndrome symptoms. The other way to tackle it is how about we block this process of conversion of tryptophan into 5-hydroxytryptamine or serotonin production. And now we have a drug that is able to do this. That blocks this enzyme tryptophan hydroxylase. So the name of drug is called Telotristat, ethyl, or Zermelo. And it was tested in a trial called TELESTAR, which showed that Telotristat reduces serotonin and which resulted in reduced frequency of carcinoid syndrome diarrhea. So right now it's FDA approved for use in the US for carcinoid syndrome diarrhea refractory to somatostatin analogs, and the drug works pretty well. It's a pill. Relatively safe medicine, but look out for nausea, abdominal pain, elevated liver enzymes. Some people rarely can have constipation. Then in that case, you have to stop the medicine. All right, moving on. Another game changer in recent years has been the Theranostics in neuroendocrine tumor. Now, you've probably heard about Theranostic in context of prostate cancer with Pluvicto. And I feel that this is just the beginning. You will see theranostic drugs for colon cancer, breast cancer, all sort of lung cancers in near future. This is just taking off. But this is a very important study that really catapulted this field into the forefront. And what do we see here? The NETR-1 study was a randomized control study testing lutetium-177 dotatate. So it's a radio-tagged somatostatin analog. So lutetium-177 is a radionuclide which emits beta radiation. When we inject this drug, it goes wherever there is a tumor which has somatostatin receptor and attaches to it. And then the radiation from lutetium-177 radiates those tumors. So it's a very targeted way of radiating just a tumor. So that's the beauty of this. And more importantly, you can actually do a dotatate PET to see if you have the receptors and only give patients this treatment who have the receptors. So you can really screen the patient very efficiently. So they studied this drug in midgut NET patients, and what they found is people who got lutetium-177 dotatate, they did significantly better than patients on the control arm with higher dose somatostatin analog. Now we have a long-term follow-up data. This is somewhere around 28 months versus, I think, 8 months. So significant improvement in the median PFS. Not only the drug improved the median PFS and then led to better stability, but the quality of life was also better in patients who got lutetium-177 dotatate. Very simple medicine in the sense 4 doses. Each dose is given through IV infusion every 2 months, and that's it. And the patient stays on somatostatin analog monthly injection after that. Now, the tricky aspect is it is a radioactive drug. So it has certain logistical requirements, either radiation oncology or nuclear medicine doctors, they administer it. They are licensed to handle radioactive compounds. So there's a specific, requirements in terms of facility. You need to have a radiation safety officer. You have the SOPs in the place and how to do it, etc. So there are some constraints in terms of who can do it. However, since its FDA approval in 2017, 2018, there are well over 200 places in the US who are giving this. So certainly it's getting more and more accessible and easier to get. This is a patient of mine who got lutetium-177 dotatate. Look at this disease. All these dark spots are somatostatin receptor positive tumors, a lot of disease. And after 4 doses of lutetium-177 dotatate, almost 60% reduction and much improvement in their bone pain. So the drug certainly works. It's very, very effective. Building on success of NETR1, a subsequent study was done that was published last year. It's called NETR2, and they now treated patients with lutetium-177 dotatate upfront. So these are not second, third, fourth line. These are anybody who's newly diagnosed. However, they picked more aggressive patients. So these are higher grade 2 or grade 3 NET patients. And what they found is patients who got lutetium-177 dotatate did significantly better. The median PFS 22.8 months as compared to control arm with high dose SSA 8.5 months. But very important factor, not every patient who has newly diagnosed NET should do this. This was a higher grade 2 and a grade 3 population. So patients for more aggressive biology, certainly this study allows us to use PRRT upfront and more sooner than later. But majority of patients are low grade. They still need to use their SSAs. You don't really need to pull the trigger on PRRT yet. The response rates were pretty impressive with lutetium-177 dotatate in the NETR2 population. The partial response almost 37%. Contrasted to NETR1, the lower grade tumor, the response rates are about 14 to 15% range. So that tells you that the biology and the reaction to the radiation is different. It depends on higher grade tumor, they respond beautifully, and the more indolent lower grade tumors, they maybe not so much. So the stability is the key there. What are some of the side effects? Usually very well tolerated drug. Lutetium-177 dotatate is, they can still have some nausea, fatigue, but usually much better tolerated. And from the times where we used to use a very emetogenic amino acid solution for kidney protection, the current amino acid that we use is much less emetogenic. So patients don't even report that much of nausea and vomiting any longer. Some people can have mild hair thinning and gotta be careful about kidney function, especially in the patients who already have some renal insufficiency. But if you have normal kidney functions, usually it's a very safe drug. One very minor or not minor, rarer side effect, but very important side effect to note is myelodysplastic syndrome or leukemias. 1 to 2% patients can have that long term. So again, it's very low incidence, but not 0%, something to discuss with your patients. All right. We are on the last stretch of our neuroendocrine tumor management, and one of the very important study that was just published a few months back, and as FDA led to its FDA approval of cabozantinib and NET this year, is called CABINET study. It's a phase 3 trial of cabozantinib in advanced neuroendocrine tumors. This study had 2 cohorts of patients. So basically it was like 2 studies in one. And one of the cohort tested cabozantinib in pancreatic NET patients, and patients were randomized into 2 arms, 2:1. So 2/3 of the patient got cabozantinib, which is an active drug, and 1/3 of the patient got placebo. The other cohort was extra pancreatic, which included your midgut or small intestinal, GI NETs, and thoracic NETs. And I think hats off to the study team. Dr. Jennifer Chan from Dana-Farber led the study, beautifully done study, and was very inclusive. There are very, very few studies that focus on all rare subset of neuroendocrine tumors. So this study looked into thymic NET, lung NET, midgut NET, pancreatic NET, extra pancreatic NETs, all sort of NETs. But not only that, they also looked into rarer subset of higher grade NET. So if you look at the grade, there were patients, these grade 3 NETs are very rare to begin with, but 6 to 9% patients were, from the grade 3, and certainly a significant amount of grade 2, including higher grade 2, would be part of that, right? So very inclusive study, because oftentimes nobody's going to do a dedicated study just on grade 3 NET. So it certainly adds additional treatment options for these rare unmet need patient population. If you look at the prior systemic therapies that these patients who participate in cabinet study, look, these are heavily pretreated patients. They're not only all had SSA, so as an analog, but several of them had lutetium-177 dotatate. Many of them had mTOR inhibitor. Some even had chemotherapies, etc. So these are very refractory patient population to several lines of therapies. And that's true even for pancreatic cohort, where all grades 1 to 3 were included. And, on an average, at least 3 lines of prior therapy, the patients who were randomized to cabozantinib. So very refractory disease. So let's look at the key results here. Patients who were randomized to cabozantinib versus placebo, for extrapancreatic cohort, the median PFS was 8.3 months versus 3.2 months. This is statistically significant and very impressive, considering we are talking somebody who's getting cabozantinib as a third, fourth, fifth line agent. In pancreatic cohort, we found even better results because pancreatic NETs tend to have upregulation of VEGF pathways, and the cabozantinib specifically is a very potent VEGF inhibitor. So we saw the median PFS in cabozantinib of 11.4 months as compared to the placebo, which is just 3 months. Very, very impressive. Another really key take-home message here is the response rate. Now, traditional neuroendocrine tumor therapies like somatostatin analog, the octreotide, Lanreotide, the response rate is 5%. mTOR inhibitor, maybe 7%. Lutetium-177 dotatate, based on its FDA drug inserts, about 14%. So there are not a lot of therapies, neuroendocrine tumor treatments, that have very exceptionally high response rate. The CEP-TEM is one of them. It can be pretty high for pancreatic NET. But most of the treatments are not that high in response rate. So if you look at the pancreatic NET cohort, there's about 18% response rate, which is very impressive. And this is a patient population that sometimes I am looking for shrinkage, especially if the CEP-TEM is not very helpful in shrinking the PNET. And now this adds another option where I can potentially shrink the disease if needed for symptom purposes or for surgical purposes. For extrapancreatic in the midgut and lung, the response rates are not that impressive. It's in line with other approved treatment for NETs. So that's something to note, at least for pancreatic NETs, very impressive response rates. Cabozantinib has been in market for a long time for several other cancers, so we all know the side effect profile of cabozantinib very well. It's not the easiest drug, especially at the highest dose of 60. So many times most of the time I start with 40, and I see it's much better tolerated that way, and patients stay on it for longer. But these are the side effects that were noted in the cabozantinib studies, and expected fatigue, diarrhea, hypertension. Those are some of the common ones. All right, for completion's sakes, additional neuroendocrine tumor therapies, these are not new. They have been in use for 10, 15 years, so I won't spend too much time on that. mTOR inhibitor was first approved for pancreatic NET based on the RADIANT group of studies, and later a larger RADIANT-4 study included the midgut and lung NETs. Based on that, we found a median PFS around 11 months versus 3.9 months, led to its FDA approval for all NETs. So just like cabozantinib, mTOR inhibitor is also approved for lung, extra lung, and pancreatic NET, so which is good. And last but not the least, after several years, AJCC came up with the next iteration of NETs guidelines. As you know, American Joint Cancer Committee has a guideline committee which defines how to stage neuroendocrine tumors, and also has some other supplemental recommendations. So this is a consensus of what we've done. You can see the publication. It's available free of cost. Basically, we have now recognized the well-distributed grade 3 category as recognized in literature earlier. The T1NXM0, early stage gastric duodenal appendiceal colorectal are formally staged as stage 1. Previously, they were unstaged because we do not have lymph node staging. Now we know the outcomes are similar, whether you sample lymph nodes for this early stage or not. So they're clubbed together as stage 1. Routine use of chromogranin is dissuaded, barring select cases. And we are slowly recognizing a newer entity with the PPI-induced gastric neuroendocrine tumors. However, it's not ready for prime time yet. With that, I like to wrap up this presentation in the last 3 minutes with a case study, and you'll have opportunity to vote on the right answer. So let's say it's a 68-year-old female with history of high blood pressure, breast cancer, is treated 20 years back, and is cancer-free from breast cancer standpoint. Was diagnosed with well-differentiated pancreatic neuroendocrine tumor, incidentally, during one of her endoscopies. They did an endoscopy ultrasound, found a 3-centimeter mass in the tail of pancreas. They did the biopsy at the same time, confirmed an NE. And since we are saying this is 2014, we didn't have the fancy Dotatate PET ready at that time for the patient. Patient got the old school Octrio scan, but did not show any metastatic disease. If you see here, this is the tail of pancreas mass here. What should we do next? Should we observe? Should we resect it? Should we radiate it? Or should we give chemotherapy with capecitabine temozolomide? Beautiful. Well, 90%, I'll go with the majority here. The surgery is the right choice. Now, observation would have been okay had it not been a 3-centimeter tumor. So when it comes to pancreatic NET, there are certain guideline recommendations. If it's less than 1 centimeter, you can observe it. If it's more than 2 centimeters, you usually want to resect it. If it's between 1 and 2, it's a gray zone. You won't be faulted for resection or observation. But since this was 3 centimeters, usually surgery is the way to go forward. The reason and the reason why we do that is we have shown long-term disease-free survival with surgery alone. So patient underwent distal pancreatectomy, splenectomy in 2014. It confirmed a neuroendocrine tumor. In the biopsy, it was grade 1, now it's grade 2. And sometimes this discordance happen. We go with a surgical path because we have a bigger tissue, and the lymph nodes were negative. This is that AJCC publication from last year. And one of the cool things about this paper is on the last page, you'll see this outcomes, 5-year outcomes, and you see for different subsets of neuroendocrine tumors. So this is a pancreatic NET. You see the stage 1, it's 5-year, it's almost 90% disease-free survival. So early stage 1, 2, and even 3, they have a pretty good outcome. All right, now fast forward to 2018. Patient was getting screened, observed after that, would get scans. One of the scans, unfortunately, in February of 2018, showed some liver mets. And you can see here these spots, hypertense spots in the CT scan, and they were biopsied and confirmed to be a neuroendocrine tumor. What should we do now? Should we observe, debulk it, start somatostatin analogs, or liver transplant? The disease is both inside liver and outside liver, abdominal nodes, and some other areas. All right. Very good. We have a very astute audience today. I'll go again with the majority. Although you can't be faulted for surgical debulking, but usually the safer bet is for progression because there's clearly progressive disease. Patient was NED, now has progression. The frontline treatment for metastatic disease oftentimes use somatostatin analog. However, if we start SSA and patient has stable disease, this is something that we can consider. If it's a good surgical candidate, we can then debulk it. But the accurate right answer by the books would be long-acting somatostatin analog. All right, and we discussed previously what led to its approval. The CLARINET study led to approval of Lanreotide. PROMID study also tested and has shown median PFS improvement. The octreotide. So both these drugs are used in the US for disease stabilization in metastatic NETs, frontline treatment. All right, so patient who started on monthly octreotide and had a good disease control. Now this was 2018, right? Now we are moving to 2022. We now have access to these fancier Dotatate PET scans. Unfortunately, one of those PET scans showed disease progression and multiple radiotracer SSTR positive liver metastases, abdominal nodes. Look at this Dotatate PET. These are called three-dimensional MIP, maximum intensity projection imaging. So this patient underwent PRRT, and look at the before and after PRRT scan, significant improvement in the treatment. Now let's play a hypothetical scenario. Fast forwarding 4 more years, it's 2027 now. A patient has unfortunately progressed again. What will we do now? Should we retreat with PRRT? Should we offer CAPE-10? Should we offer sunitinib? Or should we do cabozantinib, the latest tool in our toolkit? Wow, 100% cabozantinib. All right, very good. I think that's what probably I would do as well. Having said that, all the answers are accurate. So there are 2 clinical trials testing utility of retreatment PRRT. So the answer here is under research protocol. So you can't just randomly treat on your own. That will be off-label. So that's an opportunity. CAPE-10 is also very effective chemotherapy combination. However, my personal practice been moving away from too much use of CAPE-10 because of long-term myelodysplastic syndrome or MDS risk, especially in the era of PRRT. But certainly, it is an important drug, and we should use it at some point. Sutent, not very, it's FDA approved for pancreatic NET, but has high toxicity, is not big fan of this drug. So can be used, but later in the line. I think cabozantinib, as majority suggested, I think would be a hot favorite. And as the cabinet data showed, especially for pancreatic, very effective drug. So technically, all the answers are accurate, but I think cabozantinib would be a hot favorite for the next one. This is one of the the PRRT retreatment study. I'm the national PI on this one. So just a shout out for this study. Please consider this study if you have access to it. It's retesting lutetium-177 dotatate progression. We don't have randomized prospective data to support the use of repeat lutetium-177 dotatate. So this study is going to be very important. And there's another study testing alpha PRRT called Action-1, also very important study in this regards. We discussed a lot about PRRT. One of the things about PRRT is pseudoprogression. So try not to scan too early with PRRT. In research, we are obligated to do scans at certain frequency. So here's a patient of mine. The first scan actually showed in 2 months, showed some growth, which is actually just radiation-induced inflammation. If you follow this patient along, patient actually shows shrinkage. So that's one thing that you have to be aware of. And there are some take-home messages I would like to summarize here. So PRRT use is now quite prevalent as second-line therapies. However, there's no one-size-fits-all approach. You have to be careful about long-term myelodysplastic syndrome and leukemia risk, especially if you have a younger patient. Maybe you don't want to do it too soon. But if you have a 60, 70, 80-year-old patient, it's a very effective treatment and oftentimes have better results if you use sooner, like second line or third line. NETs are chronic indolent diseases, and prioritizing quality of life is equally important along with longevity. This is a disease that patients live for years and years. So you have to balance both toxicity and efficacy side of things. PRRT is a significant milestone in a treatment, but access may be challenging in certain remote locations. So it's good that we now have multiple other options, cabozantinib, CAPE-10, sunitinib, and so on and so forth. And these targeted therapies seems to be very effective. However, very important to mitigate side effects by dose modifications. And that's a very, very important part of management. So finally, significant process is seen all around from diagnostic to therapy in NETs. New drug development and steep growth curve, consider clinical trials. That's how we're going to take the field forward. NETs are not rare any longer. Both the prevalence and incidence suggest that. And the management really involves a multidisciplinary approach because, as you said, so some patients may benefit from interventional radiology-led liver-directed therapy. Some patients might benefit from surgical cytoreduction. And then certain patients may need PRRT from radonc or nuclear medicine. So it's truly a multidisciplinary endeavor. With that, I'd like to wrap up. Thank you again so much for your attention. It was such a pleasure to work with iHealth team on this webinar.